Hello, everybody. Welcome to today's webinar. This is Inpatient Claim Review, Current Trends, Key Challenges, and Emerging Opportunities. This is the first in our year-long quarterly webinar series that we call Payment Integrity Pulse. I'm Warren Lesniewski, VP of Product Marketing here at Cotiviti, and I'll be your host today. So thank you so much for joining us. We have another good one lined up for us today. Before we get started, anyone not new to these knows we have to do a little bit of housekeeping. So first, you can resize and move all the windows you currently see on your screen, including the slides and the presenter video, to find the layout that you like. Next, we have a couple of ways for you to reach out to us during the webinar, and please feel free to do that. So along the top navigation, you can see the Q&A button. That's important. You use that to submit your questions to us at any point, and then we're going to do our best to answer the questions after the webinar. We encourage you to submit your questions throughout the presentation rather than waiting till the end, and that helps us ensure to try to get to all of them. You can also use the Contact Us button to send an email to send us a request for any additional follow-up or questions on today's webinar. Around the edges of the screen, you see additional resources, including links to useful assets that are related to the webinar. So there's images on the right. You can click to get to our new ebook called Future Proofing Payment Integrity. There's a requested demo button. There's a case study around prepay DRG review. And so please utilize those at any point as well. At this time, we do not provide copies of our slides, but a link to the on-demand recording will be sent to registrants and attendees just within a few days. And then finally, please take a moment at any point during today's webinar to answer our quick survey. And as always, your feedback is extremely valuable and will help us determine future topics for our webinars. So with that, I will introduce our speakers for today. We have Amy Carrollton. She's the Vice President of Product for Cotiviti's Clinical Chart Validation Solution, where she leads support for those clients and focuses on long-term strategies that reduce total medical costs for inpatient services such as DRG, short stay, readmissions, SNF, IRF, also complex outpatient reviews. With more than 13 years of healthcare payment integrity experience and a robust clinical background in nursing, Amy drives CCV product innovation by directing investments and developing new enhancements and audit types to better serve Cotiviti's client base. Jenna Riley is our Senior Director of Payment Accuracy Solutions. She drives the components of strategy and development for Cotiviti's prospective products. Prior to joining Cotiviti in 2011, she held a variety of roles building and managing complex review services, bringing a comprehensive understanding to the organization. So we have a nice mix, I think, of clinical and technical today. So with that, I think I'm going to turn it over to Amy to get us started.
Thanks, Warren. We're excited to be here and be honored to join the Cotiviti Payment Integrity Pulse webinar series. As Warren said in our background, a fun fact for Jenna and I is that we spent more than a decade at Cotiviti, which means it's giving us a front row seat to the ongoing transformation and year-over-year growth in the healthcare space. The key question we are asked from our health plan partners is not just how much inpatient is growing, but why? What is driving that increase? Is it sepsis? Is it the older population? And so that's why we're here today, to talk and share insights into the inpatient analysis that Jenna and I did with our team members. Our goal from this session is a clear understanding of the trends driving inpatient spend across lines of business, regions, and even digging deeper into sepsis. Ironically, as we're getting ready for this webinar, there was a Boston Globe article that came down with a title of around Curious Case of Sepsis, which further backs our findings that we'll share today. An additional goal we have is how important it is to standardize complex data sets to ensure maximum value in both post and prepay landscape regardless of documentation requirements. And lastly, as Warren had shared, I am a nurse by degree. And so with my clinical background, I will take the conceptual concepts to a real life scenario and walk through claim examples to articulate how we find those additional values. So we're going to dive right into the trends. The trends that we are seeing is a $4 trillion growth in spend, and we know that that is only going to increase. Let that sink in a moment. $4 trillion. Our healthcare system is fragmented, it's expensive, and it's exhausting to navigate. Not just for you as health plans and for providers, but even for the members. The biggest challenge we face is that healthcare economy continues to defy the laws of economics. Nearly 20% of the US GDP is tied up in healthcare costs, making it a larger economy than countries like Japan or India. Staggeringly, with the bulk of the baby boomer generation yet to age into Medicare, that figure that I have of the 4 trillion is expected to increase up to 7 trillion in just 2 years. Unfortunately, that spend requires attention in terms of where and how else we can combat that increasing growth. And what we have seen is that there is waste and inefficiencies that create extra work in the ecosystem. And why we're here today is to analyze that and how else and where else we can combat that rising in costs. Under the admin spend, it's projected that 25 to 50% was driven by waste, and that another 20 to 40% of cost savings could occur with automation and AI. In the delivery of care costs, which is the 3 trillion spent, there is about 12% of claims in 2024 that were denied on first submission, and almost half of them were denied non-clinical errors. My recommendation is to lock arms with payment integrity partners to stop the spiral in costs and find ways to reduce the medical loss ratio and the admin loss ratio, or what we call the MLR and the ALR. As we advance here, what's important to recognize is the growth within inpatient spend is not driven primarily by higher costs per claim. And I'm just going to pause there and repeat that the inpatient spend is not driven primarily by higher costs per claim. It is driven by the increased utilization, more members, more admissions, and shifting demographics. Speaking of shifting, my colleague with me is Jenna. And Jenna, I believe you are a part of the regional shift that we are talking about today as well. Anything you want to add?
Thanks, Amy. Yes, I am sure part of that regional shift to the Sun Belt area of states like Texas, Florida, and Georgia. Ironically, I went from New Jersey to Georgia and then Georgia to Florida. So we are seeing a prominent demographic trend into the Sun Belt states where people are moving for job opportunities, affordable housing, lifestyle preferences. In my particular case, it was a lifestyle preference. The North got way too cold, and I much prefer it down here in the warmth. But this migration is what we're seeing is increasing the higher utilization rate in the southern states, directly correlating to higher membership numbers in these regions.
I'm going to have to come visit you down south because it's up cold. It's cold up here in the north.
Sure.
So thank you for that, Jenna. So as we advance forward in our trends, we did analyze by line of business. We know that there is unique populations within each line of business and thought it was critical that we analyze those. So there have been distinct patterns that have emerged when we analyze commercial, Medicare Advantage, and Medicaid. And with that, we see that it is an increase in inpatient spend growth is structural. It's not temporary. It requires that intentional payment integrity approach, and that within Medicaid specifically, there was an unwinding of continuous enrollment following the public health emergency, which created significant churn. Millions of members went through redetermination, and unfortunately, some losing coverage and others have shifted plans. Inpatient spend within Medicaid continues to be driven by maternity, behavioral health, and psychiatric admissions. As we shift over to Medicare, the demographic trends are the dominant trend here. I'm sure that's no surprise to anyone on the phone, that as the population ages, we steadily see growth in admissions and spend within Medicare. Specifically, we've seen that sepsis is a leading cost driver within the Medicare population, which we're going to go into in a few moments. Jenna, do you want to add around commercial and what we've seen in the data?
Yeah, sure. So commercial is a little bit of an outlier kind of to the earlier comments that Amy has mentioned, that cost isn't a big driver, where we're seeing inpatient spend that slightly differs in the commercial arena, where we have seen highest back-to-back cost increases between 23 and 24, driven large in part by high unit prices. So there's still a varying disparity across the commercial lines of business in the cost of inpatient stays, as well as the rising inpatient intensity. Here as well, a lot of the cost drivers are around maternity, with the added expensive surgical procedures like spinal fusion. So there was quite a bit of a jump in the commercial arena around spinal fusions.
That's interesting, Jenna, about the spinal fusion. So thank you for sharing that. Just to summarize here too is, again, it's important to look at trends by the line of business, because each one, even within inpatient, and Jenna, you would know this as well, right? But the technical aspect of each one has a different grouper as well. So looking at that can drive the cost, whether you're grouping with MS DRG or APR DRG. But having that expertise within each line of business helps to layer in that additional expert review of the claims. So as we navigate from the higher, broader stroke of the overall inpatient spend to where we just covered the trend by line of business, the next natural progression was down to the DRG, as I mentioned. There's MS DRG and APR DRG. And as we have seen that sepsis doesn't focus on a line of business. It's across all lines of business. And our question is what is causing that? What's causing the drive in sepsis? Is it the sicker population? Is it the way that it's being coded and documented? And so what we've analyzed is that sepsis represents a substantial portion of the total of inpatient spend. Among Medicare members, it accounts for a significant share of hospital costs, with meaningful impact in commercial and Medicaid populations as well. What's notable is that overall sepsis-related hospital costs have remained relatively stable over the past several years, suggesting that the opportunity is less about volume growth and more about accuracy, documentation, and the validation of the severity of the case. Because sepsis are high cost and they're clinically complex, small documentation or coding differences can materially change how a claim should be paid. That makes sepsis a prime example of why review and data depth matter. As you take a moment to analyze your own landscape that you support today, do you have a good pulse check on your sepsis claims? Are you layering in the clinical and coding guidelines? How is the documentation within your organization? Of course, these are rhetorical questions, but something that you should pause and think about and look at back to how is sepsis billed within each line of business? How is sepsis documented, and how is it coded? So as we transition over, we do want to poll the audience and be able to get your feedback. So we're going to take a moment here, and if you could share your thoughts with us. Where else, how else would a trending of inpatient data be useful to you and your organization? We've talked about the lines of business. We've talked about regional. We've talked about DRG. And another one, we're just getting through the winter months. And so with those winter months, we know that illnesses can trend up and down as well. So looking to see, is that of value to share trends based on the season? Jenna, of course, she lives down south, so she doesn't see as many seasons as I do up north. But definitely another area we thought about analyzing as well. And then lengths of stay. We know that lengths of stay are important to providers, right? We don't want patients in the hospital forever. So we want to see how we can stabilize them and recover them at home. We know that recovering at home is definitely a key way for members to get better, faster. They're more comfortable. So looking through that as well. And then revenue code. We know that there's pharmacy codes out there and medications that folks will have interest in as well. So looking to see if that is of interest to your organization. And maybe there's another one that you want to look at as well. We're open to that. And as Warren had stated, there is the Q&A session. So feel free to add additional topics as well if we don't have them covered here. Jenna, anything else you want to add around the trends as we're waiting for our audience to respond to the poll?
No, I think you've summarized that really nicely, Amy. Region is an interesting one, which also coordinates ironically with season. Depending on, as you mentioned, depending on what region you are in, you may not see certain seasons. Although I will tell you, it was a bit chilly down here in Florida this season, but we'll go ahead and move on to the poll results.
Awesome. So as we move forward, and what we thought, Jenna, it would be by DRG. And we do know that, again, DRG broken down by MSDRG, APR DRG, that they do require different skill sets in terms of how those are reviewed. We know that APR DRG also layers in that severity of illness. And so that is one we would take as a feedback and continue to look at. So thank you for that. Now this is where it gets into the fun technical part, and this is where Jenna will jump in. But as a visual, I wanted to make sure we took the time to look through the end-to-end continuum. I thought this did a great job articulating where member enrollment all the way through to post-adjudication prepayment through the payment and recovery life cycle. Each one of these boxes, I'll call it for lack of a better word to use, requires unique data. And so we can talk about member enrollment or prior auth check or the 837, the 835. All of those have to translate into data attributes to be submitted to the health plan to be able to start the payment process. And I can say, and I know Jenna can say, we've been around long enough. There are homegrown systems, there are standardized systems, and the data comes in and out in different forms. And therefore, fragmented workflows, fragmented data sets can become a challenge. That as long as we have good data coming in, solid data coming in, you're going to get solid data resulting in solid selections, outputs, etc. So as we go to the next step here, this is where I'm going to connect with Jenna and say, Jenna, give me some more technical details around the data for our analysis.
Yeah, sure. So, one of the biggest challenges with inpatient payment integrity is that DRG claims are inherently complex. Every small detail can, or even the smallest of details, can materially change how the claim should be paid. Unlike simpler claims, inpatient DRGs are influenced by a dozen of variables, from diagnosis sequencing to procedure sequencing, POA indicators with the diagnosis, the severity when you're talking about APR DRGs, or even the MCC and CC type DRGs, the complications. A single missed detail sent in the data can mean the difference between an accurate payment and an overpayment. And that's why integrating more complete inpatient data into the analytics is a critical component when you're analyzing your inpatient utilization and spend. When we bring in the full diagnosis set, and in cases of procedures, the full procedure set, the POA indicators, the claim history, we have seen a dramatic improvement in the selection accuracy and the forecasting. This is what allows your teams to prioritize the right claims and not necessarily just more claims. The better data means fewer unnecessary audits. It's driving more precise reviews, more precise selection on truly what requires a review, whether, and we're going to get to this in just a few slides, but whether that's an automated review, a review with a human eye against the data, or a documentation review. So there are very important factors when it comes to the data to reduce redundant work, limit provider abrasion, where you might have previously missed a piece of data element that caused a denial, and the provider says, "What are you talking about? I sent you that diagnosis." So things like that are critical components as we review through the inpatient realm of claims to ensure that we are producing the right answer at the right time. A good example of that is specific around the documentation-based reviews. Our access to full clinical documentation doesn't just increase the findings, but it increases the sustainability. So we're consistently seeing higher change rates, higher provider agreements when documentation is available. So that's another data element on top of just the pure claim data elements that drive to the decisions grounded in the full clinical picture.
And it's interesting data, Jenna, how you called out about the data and the 25 diagnosis codes. I know that that's another piece of why we do very extensive testing, right? As a technical person, it's better to test and test and test and make sure we get that right data, because when we do go live, it's critical to the selection logic. And as you said, reduce the provider abrasion. So the other piece within this is making sure that not only when you go to production and you're actually selecting, but that there is critical paths of testing, and you really test how the data is coming across, because one data element can really cause a different output. And we want to make sure it's sustainable. We're respectful of your provider network. We're respectful that we know any claim we perform that outreach on behalf of your organization could cause providers to be concerned, upset, etc. So testing is critical, data attributes are critical, and really having that end-to-end rigor to be able to go live and get that in production. So as we continue to advance here, as we stated, the complexity of the data sets, outdated systems, there are numerous systems that we work on behalf of, and our biggest message as well is meet you where you are, and let's see how we can partner together. If we are not looking at the foundational of how the actual data is coming in and out of your system, in and out of the clearinghouse, then that's where we want to meet you so we can get the right data. The other best practice that we have is a content team a team that's dedicated to staying up with the latest state and federal regulations that they're always analyzing. So Jenna and I are here today to talk about a trend, but we have teams and teams of data scientists and others who are constantly looking at the millions and millions of claims that we get and saying, where else, how else do we continue to analyze and find that additional leakage and analyze those and select those. The other piece is the having the qualified experts. We do a lot of work with data, but we also do a lot of work with our people. We take it that within that being credentialed, having that background of clinical coding, et cetera, is to ensure it's a sustainable review, a sustainable outcome. In terms of, again, the abrasion, make sure that we're soliciting the right claim at the right optimal point to drive that value. So overall, our comments are to ensure that you look at the foundation, which is the data, and then you're looking at how you're always analyzing, trending to stay ahead and to continue to add new content. We like to say, no review is stale. It's always ever learning, a continuous learning. And then our clinicians, we are working through and keeping them up to date with the latest and greatest. We know that the state and federal regulations are constantly changing. I know that I get updates numerous times a day. And so keeping up with that keeps us in line and compliant with when we're doing our reviews. So as we transition from that, over to Jenna. Jenna, can you give me a little bit more about complex reimbursement and that aspect?
Yeah, absolutely. So transitioning from the data to the intervention point, if you will, there's fundamental differences between the intervention points, from automated edits to human reviews to documentation-based reviews. And understanding these distinctions is critical to building an effective strategy to addressing overpayments in inpatient spend. The automated edits are going to operate at scale, applying codified rules and data logic to the claims data. These edits are really ideal for clear-cut scenarios such as eligibility validation, coding mismatches, duplicate detection, and even policy-based denials, offering speed and consistency as well as cost efficiency. But they're inherently limited to the structured data and the predefined logic, which is why we've been spending the last couple of minutes here just driving home the necessity of data and quality data elements, because that really is where our automated edits or your even inherent into your claims adjudication system automated edits are really going to strive to catch things and avoid the manual work that comes with the next two intervention points. So when clinical nuance and documentation and interpretation or context-dependent judgment is required, then automation alone isn't sufficient. And that's when you move into the human review. The human review introduces the clinical expertise and a judgment into the process. The analysts, the coders, the clinicians, they're going to be able to evaluate the claim elements that fall outside the rigid rule sets. They're going to be able to identify patterns, emerging billing trends, and even gray areas that require interpretation. So while you're more resource intensive, this layer is going to add flexibility and adaptability that an automated alone system cannot replicate. Moving into our more complex review with the documentation, so yet another data element layered on top. So we've got our claim data, now we've got a human, and now we've got a human plus documentation is really where you're going to get the most comprehensive level of scrutiny. Incorporating the clinical documentation is going to give the reviewer the ability to assess the severity of illness, the level of care, the documentation integrity. This approach is really for your very high complex inpatient stays, your high cost outpatient procedures, your post-acute services where claim data alone or claim data, even with that human judgment alone is not going to fully reflect the patient's condition or the appropriateness of care delivered. So this whole model in itself, it's not really a one size fits all, but it's a right intervention point based on the right information at hand is what's going to align your strategies for a cohesive life cycle approach. Again, automated edits, targeted human review for efficiency, and data-driven selection and clinical documentation review is what's going to strengthen an oversight for billing errors. Amy, did you want to add anything to the continuum care?
Yeah, you did a great job. I mean, what I will say is that it's layering in and layer and layer and layer, right? I think the biggest point we can articulate is it's not one line of defense, one line to do it. It is multiple capabilities across the continuum. It is critical, and that, again, it is to ensure that we have the right intervention point, as Jenna said. We have the optimal output that we can based on it, and allows us to go deeper. So it's not just the low-hanging fruit. It's not just the simple cherry picking, but it is upfront where we know it shouldn't even be paid, all the way down to let's dig into that complex review and really find that next level, next detail of findings. So if we, again, translate over to an example. So Jenna and I have conceptually talked a lot about this, but now it's time to say, so what? So what does that mean for me? What's in the data and what's an example? So for the next few minutes, I'm going to walk through examples to bring to life what we're discussing here today. So within this scenario is readmissions. There can be multiple admissions. Patient is admitted, and then they're readmitted, unfortunately. And so where we have multi-layer capabilities is the claim editing, as Jenna said. We get that data attribute in the prepay space. And within that prepay space, we're looking at those data elements, and we are analyzing those with a high degree of confidence that even without the documentation and claim editing, we can solicit, or we can make a recommendation that there has been an overpayment on the inpatient stay. Then we layer in that next layer of expertise, which is the review without chart. Again, there is the intervention with staff to oversee it and deny an inpatient stay, then layering in again with a chart. And again, that's all in the prepay. So we can go from upfront without documentation through to the complex documentation. And then even fast follow would be once the claim is paid, we as well could solicit in. And folks will say, well, why don't you just catch everything up front? I love that question. I think it's one of my favorites, is because it all depends on the claim and why and where we can intervene with it. In terms of, again, if a claim is excluded from prepay, let's continue to work it in the postpay space. Vice versa, if it can't be reviewed in postpay, let's put it on in prepay. But having both interventions of reviews for inpatient, both in the prepay and postpay, complements each other. To be able to, again, intervene at the right time based on the configurations that have been set up. And then this is where I'm going to take a minute. We're going to go into case studies. But I want to remind, as a nurse, that these case studies are members, right? And so these members have received services on behalf of what they needed to be seen for. And they'll see the physician and they'll be inpatient, et cetera. But sometimes as I go through these and present, it's a reminder of the member. And this is why I do what I do. And I'm sure it's why Jenna does what she does, is there's a lot of waste, and we want to make sure that we look at them just as if they were one of our family members. So this case example, this patient was admitted with pneumonia. And based on the data attributes that we received, Pneumonia was the principal diagnosis code, and acute respiratory failure with hypoxia was a secondary diagnosis code. We have a high degree of confidence that soliciting this claim and making a recommendation that the pneumonia as the principal diagnosis code should not have been in that order. So our recommendation was to resequence, mean putting acute respiratory failure with hypoxia as the primary and then putting pneumonia as the secondary. And when we did that, the provider agreed. They did agree that it should be resequenced even without documentation. So again, we are not wide open soliciting everything and anything. It is really factually data-driven, analytics-driven that this was an overpaid claim, overcoded claim that warranted the pause, review, and make our recommendation. And then the other one we have is sepsis. As I shared, sepsis is an ongoing DRG trend across. And so this one was a patient came in with flank pain. We did solicit that medical record because of the complexity with sepsis that we wanted to make sure we took the holistic picture and solicit that medical record. And with that medical record, layered in our expertise, and with that identified that sepsis was not the best DRG for this claim. That based on the clinical coding and documentation that we reviewed, our experts recommended that it was not sepsis, but actually that it was a kidney and urinary tract infection, which if we all think about our kidneys are on our flank, they're on our sides, right? So again, it is going back to the member, what's documented, how it's documented, and then could there be overbilling? And if so, our algorithms solicit it to analyze and find where it could have been better suited through a different DRG backed by clinical and coding documentation. So with that, again, thank you for your time today. Jenna, I'm going to shift it over to you to wrap us on up here.
Yeah, sure. Thanks, Amy. Just pointing out in everyone's time, being conscious of time, we really want to just put forth kind of, okay, so what does this all mean for you? You sit here and say, this is great information. Thank you for sharing with us, but what does this mean? And really what this means is Monday morning or Friday morning, hopefully not Friday afternoon, but Monday morning, what should you be doing? You really should be looking to stabilize your inpatient spend by targeting high impact opportunities using existing data and capabilities. Take a look and prioritize your high cost, low volume inpatient claims. Identify in your data your DRGs and admissions and facilities that are driving a disproportionate spend against your current editing or review activity. I think we've driven home that there is a high focus need on sepsis, high severity readmissions, complex surgical cases where small documentation or coding gaps drive large financial impact. Assess your current claim review across the continuum. Do you have the right intervention points from automated edits to coding to human review to documentation review? Is all being applied? Is there a gap there? Where are the gaps and where are the claims flowing through those gaps to identify where to beef up the scrutiny to risk? In the next 90 days, create a unified inpatient risk strategy that leverages provider billing variability, insights to optimize claim selection, strengthen your cross-functional alignment. Amy talked earlier about all the cross-functional alignment that drives success in a review program and drives sustainable payment integrity outcomes. Analyze your provider billing patterns for variability. Look for your outliers. Look for your outliers by a DRG, by severity, by length of stay, and by diagnosis sequencing. Use these insights to refine your claim selection logic and reduce unnecessary provider abrasion. Align your clinical coding and analytics stakeholders. Ensure your clinical reviewers, your coders, your analytics teams are working from a shared inpatient risk framework. Establish a consistent criteria for escalation from automated review all the way down to clinical and documentation-based reviews. And then long-term, over the next year, build a sustainable and scalable inpatient payment integrity program that adapts to evolving utilization and data complexity. Expand your data integration for smarter claim selection. Incorporate richer data elements. I think full diagnosis codes, POA indicators, claim history into your analytics models. This is going to improve your prediction accuracy and your prioritized claims with the highest likelihood of findings. Standardize your review patterns and your claim complexity, and on and on and on. So these are just some highlights to things to think about, things to take away from our little fireside chat here today, to really hone in on how to bring forth your inpatient review programs. And I think now, Warren, I'm going to turn it back over to you for some Q&A.
Yes, we do have a few minutes for Q&A, so thank you, Jenna and Amy. A reminder to everybody, use the Q&A chat function to ask any questions that you might have now. We'll try to get to as many as we can. So let me start off, and I don't know when this came in. It sounds like this one pertains to like towards the beginning, so maybe you, Amy. If inpatient spend growth is being driven by utilization rather than higher cost per claim, where should payment integrity teams focus first?
Yeah, that's a great question. Thanks, Warren. The biggest opportunity is in high cost, low volume claims, where small documentation or coding variances create an outside financial impact. Again, driven by utilization rather than higher costs. That could be sepsis. It could be the high severity of readmissions or complex surgical admissions. So it is important to prioritize claim selections and then using that richer data set. As Jenna has shared, richer data set is going to drive that higher review process.
Okay, thank you. Next question. How do you determine when documentation is actually needed versus when expert review without records is sufficient? I know you talked a little bit about that.
Yeah, I can take that one, Amy, if you want.
I was going to say, sure. Jenna, you want to take that one? Thanks.
It comes down to the claim complexity and the clinical nuance. The automated edits and expert review without documentation works well for the clear-cut scenarios. I think I mentioned a little bit earlier, the clear-cut scenarios like duplicate billing or policy-based violations, or even some of the examples that Amy gave on the readmission, on different types of readmission and where they fell along the continuum. While the documentation review should be reserved for cases where severity of illness, principle of diagnosis, and level of care cannot be validated from the claim data alone, where that documentation really is the critical component along with the clinical expertise to be able to review and reduce unnecessary chart requests while preserving strong outcomes. So it's really the documentation comes down to is how severe is or how complex is the claim, and is it going to require the medical record or documentation to validate that severity and diagnosis.
Okay, thank you. You may have answered this next question, what you just said, but perhaps there's an expansion. The question is, how can health plans expand inpatient review programs without increasing provider abrasion?
Yeah, so provider abrasion, is really minimized by being more precise, not necessarily more aggressive. And that's where targeting better claims, more consistent review criteria, utilizing upstream interventions where appropriate, pausing claims for expert validation before denying them, limiting documentation requests is really what we find where provider abrasion kind of gets a little bit out of hand when providers are socked with, requests for thousands and thousands of records. So that precise intervention is really what's going to drive the less provider abrasion by, I'll call it, scaling your inpatient claim volume across the continuum based on whether or not it can be done with or without documentation.
Got it. Thank you. And this 45-minute scheduled webinar, so to make sure we're cognizant of that timing for everybody, we have time for one more, and I think it's Amy probably. So in sepsis admissions, is the opportunity around volume reduction, or is it more around documentation severity accuracy?
Yeah, so just to summarize that, the question I think I heard was around sepsis and how best to review those claims. So within sepsis, it goes back to the validation. So with that, around soliciting that medical record, what is documented, looking at the claim in its entirety, looking at the medical record in its entirety, and looking at the clinical coding documentation within that to further back to sepsis versus could it be a pneumonia instead of the sepsis. So it really digs into the analysis within the medical record and how it meets clinically. So whether it's through lab work, it's through chest x-rays, the SOFA score, et cetera, all of those attributes are analyzed again to see, does it warrant sepsis coding or does it warrant a different DRG that should have been billed?
Got it. Okay, thank you. So that does conclude today's webinar. Thank you again, Amy and Jenna. If you do have further questions that after we hang up here, please, again, you can hit the contact us button and send an email, and we'll try and get back to you. We'll be reaching out to you also by email shortly with a link to the on-demand recording. And don't forget to take a moment to answer our survey about your experience today. So thank you for joining us, and we look forward to seeing you again soon.